So now again a question to the audience. When kidney function declines below the 30 ml per minute, should all DPP-4 inhibitors be stopped? So an eGFR below 30, then we enter into the CKD stage 4 stratum. So now the question is, should they all be stopped? Option A, yes. Option B is no. So we'll have a look at the results. The answer is no, and that is absolutely true. All DPP-4 should not be stopped. DPP-4 inhibitor class is good in the sense that there are a lot of data available already in those with renal impairment for most of these. And what it tells us is that you can reduce the dose. And if you have, and you can use many of the other DPP-4 inhibitors, apart from linagliptin, also in renal impairment. But then you have to adjust the dose. This is the key difference between linagliptin and the others. And the reason for that is quite clear because DPP-4 inhibitor class, most of them are excreted via the kidneys, while linagliptin is not excreted via the kidneys. But it's also another string attached here. And that is that although it's not excreted via the kidneys, linagliptin is filtered in the kidneys and it's reabsorbed. So you expose the kidney cells to linagliptin, but since it's not excreted, you are not having accumulation of the drug. So this is a unique aspect of the linagliptin. And now the question is then, what about if it's different than the others? If you use linagliptin in renal impairment, what do you expect from the efficacy in terms of reduction A1C? And this slide shows you that 0.6% reduction A1C, irrespective of if you have normal kidney function, mildly reduced or moderately reduced kidney function. So this is very good news. And of course, you can also see on the right-hand side here, if you have severe kidney impairment, 0.7. Irrespective of kidney function, the effect is exactly the same. So it's a unique drug in terms of its excretion, and also that you can expect the same effect at any stage of kidney disease. So then, if you come back to the single pill combination of Lina plus metformin, and now if we prescribe a single pill combination to some of our patients, then we have to be vigilant in terms of the renal function. And this is not only true for glucose low medications. This is true for any medication we are giving to our patients. We always have to be careful what is the renal function and make sure that any of the medications are not accumulated. So when it comes to the glucose low medications, then of course metformin is the first line drug, and now in this patient case we have then combined with linagliptin, metformin and linagliptin. But you can see that when we enter the stage of CKD 3B, that's an eGFR of 45, we need actually to make sure that the dose of metformin is halved. So in that case, we should prescribe linagliptin separately and also the metformin separately, not as a single pill combination. Until that, we can use a single pill combination very nicely, because you can see that if you have an eGFR below 30, metformin is not recommended. So, but below 45, you can still use 1 gram max, but to go down to 30, you have to stop the metformin. But still, you can see that linagliptin can be used. Now, at this stage, let me draw your attention to a fact which is very problematic when we are dealing with patients with CKD stage 4 and 5, when it comes to glucose-lowering medications. Basically, sulfonylureas are contraindicated. Insulin is problematic also because in the same situation as with sulfonylureas, we run the risk of severe hypoglycemia. What about glinides? Yes, also the mode of action is such you run the risk of severe hypoglycemia. So 3 medications are problematic in this patient group. What about thiazolidinediones? No, because you have the fluid retention in this patient group, so you cannot use them. What about metformin? You can see from this slide it's not recommended. So what's left? So then we have the DPP-4s, and so linagliptin can be used also in these patients, even without dose adjustment. And this is again because of it's not excreted via the kidneys, and I already was alluding to that, which is different from the other DPP-4s that are excreted via the kidneys. So if you prescribe any of the other DPP-4 inhibitors to any of your patients, make sure that you adjust the dose accordingly. This is important in order to avoid any accumulation of the drug. So this is just then to highlight again that it's a little bit problematic if you're using the other DPP-4 inhibitors because you have this dose adjustment hanging above you. So my recommendation then is, of course, to use the one that is simple to use, and just keep in mind that the EGFR 45 is where you have to then try to split a single pill combination. So linagliptin can be an option for a broad range of patients with type 2 diabetes, and I think it's always very important to keep in mind that the patient with type 2 diabetes then come in many shapes, and since they come in many shapes, we need to be careful when we tailor the treatment, and linagliptin can be used to any. Although the patient can have any characteristic, they are elderly, they have reduced kidney function, reduced hepatic function, they have comorbidities, and any background therapy. A DPP-4 inhibitor, especially, of course, the one that you can use one dose and once daily, linagliptin is a good choice. So the key learnings from this patient is fixed dose combinations are helpful to ensure treatment convenience. And of course, if you have polypharmacy, that's something that you need to consider. And risk of long-term renal decline should be considered when you tailor the treatment. And of course, I think it's also important that if you use a single pill combination, you have to monitor the renal function, and you can use it down to a CKD 3A or the beginning of 3B. Then you have to split the single pill combination. So these were the key learnings from this patient.